I'm Dr. Fuller. I'm one of the bariatric surgeons at Scripps Green Hospital. On behalf of my partner, Dr. Takata, I'm going to present a bariatric orientation for you this evening. So I'm going to go through some slides that kind of give an overview of the program, as well as giving a bit of a philosophy about bariatric surgery. So at the end of this talk, there'll be time for you to ask questions, and we'll have a question and answer session. So let's go ahead and get started. Well, this is just an outline of what we're going to talk about this evening in rather broad strokes. We're going to give a definition of obesity that is more or less a working definition for the purposes of bariatric surgery and defining what constitutes the criteria for a patient to have weight loss surgery. And we'll talk about the role of surgery and how it can improve the quality of life of our patients. I'll talk a bit about how we actually select our patients, and beyond the standard criteria, what constitutes a patient who's going to be ready to have bariatric surgery. We'll talk a bit about the results of bariatric surgery and how we measure those results. And of course, I'll discuss the surgical options, which primarily includes laparoscopic Roux-en-Y gastric bypass or the laparoscopic sleeve gastrectomy. The laparoscopic gastric band is more for historical reference. It's really not a surgery that we're doing in 2022. This is Scripps Green Hospital, where if you're on this presentation, you should be having your surgery completed. It's in La Jolla, and it is bounded by the Torrey Pines golf course, which is indeed a world famous golf course. It's kind of a nice place to recover. When you're on 4 West, which is the ward where our bariatric patients go to after surgery, that ward overlooks this golf course, which is abutting the Pacific Ocean. You can see from this slide that we are an accredited center of excellence, and that means that we are a hospital that participates in the MBSA QIP program, which is a national registry of patients and hospitals that are committed to excellence in bariatric surgery. So we meet criteria that is established by healthcare professionals in bariatric surgery and weight loss surgery that are high standards. And that's how you can become a center of excellence and maintain that excellence in having excellent patient outcomes. This slide just gives you an idea about the breadth of our program. We have a number of individuals in whom you will interact with, some of whom you may have already met. And I'm not going to go through each name on these on this slide here, but you can see the main participants there: dietitians, physician's assistants, medical providers, psychologists, nurses, the surgeons, of course, and surgical schedulers such as Marcia Flores, whom you've already interacted with. And we believe that one of the advantages of our program is that we have a strong team that's been together for quite a long time. And each one of these individuals is essential to really helping you have a great outcome and a great experience around having bariatric surgery. Now, you'll often hear about BMI, body mass index. And for those of you who don't know, this slide gives you a definition of that. The weight in kilogram divided by the height in meters squared. And the stratification of the BMI is broken down as you can see on the slide. And what's most notable for our patients is that to qualify for a bariatric surgery, typically your body mass index is 35 or greater. Now, when it's between 35 and 39.9, typically we would expect that there are medical problems such as diabetes, hypertension, obstructive sleep apnea that go along with the obesity. And this is an insurance requirement. When patients' BMI is greater than 40, you are a candidate automatically for surgery, regardless of your comorbid conditions, so to speak. So this class 2 and class 3 obesity, these are the individuals who are indeed candidates for surgery. Now, when you look at our country, and we have maps that detail over the last 20, 30 years how obesity has impacted each of the states. And you can see that in large parts of our country, 30% of the population and higher are struggling with the disease of obesity. And we know how impactful this problem can be. It is a problem that affects pretty much all organ systems. And this manifests through the disease processes that affect the cardiovascular system, pulmonary, gastrointestinal, gynecologic, urinary, metabolic, neoplastic, neurologic. And these are the diseases that you are familiar with, including diabetes, hypertension, high cholesterol, various cancers that have a high association with obesity. Additionally, there's a significant economic toll that goes along with this condition. And we know that in our society, there is significant social stigmatization, as well as, and maybe as a result of this social stigmatization, significant psychological disease and psychological conditions that go along with obesity. And so it's a problem that is multifactorial and affects much of our patients' lives in so many different ways. And from this slide, you can see just the variety of medical conditions that are associated with being overweight and obesity. I like to include this slide because it more or less corroborates what we already see in terms of the natural history of excess weight and mortality. And so that in men and women, as the weight increases and as your age increases, your risk of mortality increases. And this has been borne again and again in the literature. This particular study is from 2006, and it was from the New England Journal of Medicine. And since that time, and even shortly before that time, there have been a number of studies detailing this phenomenon. And so what we are aiming to do in performing bariatric surgery is to help our patients to revert from that process, to forestall it, and ultimately live better, longer lives. Now, this slide, is more or less self-explanatory. There are a number of causes that we can pinpoint that lead to the condition of obesity. There's certainly metabolic concerns. There's a variety of environmental factors. We know about the hormonal predispositions that some patients may have that come from genetics. And we know about the neurologic changes or the reward pathways that we are often trying to break in dealing with this problem for our patients. So what do we do as surgeons? What can we do? Well, the slide you see here really illustrates how bariatric surgery over the last 30 years has really become a prominent tool in our toolkit in treating patients with this problem. You can see from this graph, right around the turn of the century, there was an exponential increase in the number of these surgeries that we perform in this country alone. There's several reasons why that is the case, and I've listed some of them in this particular slide. But probably the most important one would be number 4, the introduction of laparoscopy. And laparoscopy, not to be arthroscopy, is the conduct of surgery on the abdomen or in the pelvis using small incisions. And so rather than the large incisions of old, we can perform these complex surgeries using just small incisions, which has a number of different advantages for our patients. There's less pain after the surgery, which leads to a quicker recovery, and less pain leads to fewer respiratory problems. Additionally, with the smaller incisions, there's less wound complications that can be highly morbid for patients when there's a large ventral hernia that occurs after these surgeries from the old large incisions. We know that the cardiorespiratory function is much better in patients when they have small incisions. And I can tell you, as a surgeon who was a young resident in the late 90s and early 2000s, having seen open surgery for bariatric patients, it is quite a night and day change in the recovery. And so I think, along with the other items I've listed in this slide, the laparoscopic technique and its introduction is one of the more prominent reasons that bariatric surgery could be delivered safely to our patients, and why we really started doing so many more of them. We started doing so many more of them because, well, we recognized for a long time that even with the open surgeries, surgery was the best means of sustained weight loss for patients with class 2 and 3 obesity. That was already well known even before the introduction of laparoscopic techniques. We also knew that surgery really does reduce medical problems. For those patients with diabetes on multiple medications, in many cases, you can come off of all those medications. Similarly with hypertension, if you have obstructive sleep apnea, getting rid of your nightly CPAP. These are among the benefits of weight loss surgery. But it's important to recognize that surgery is a tool for weight loss. It works in conjunction with patients who have the ability, who have the motivation to alter some lifestyle habits, and in some cases to adopt new habits or adapt their old ones. So you don't want to look at surgery as a cure. Surgery should be looked at as an adjunct to what you're going to do as a patient to get the sustained weight loss and ultimately have long-term success. As I mentioned before, though, in our program, we strongly adhere to the philosophy that a multidisciplinary team is key, because we need the inputs of everyone, from our dietitians to our psychologists, to our nurse practitioners, to our PAs, to our other clinical staff, and of course from our surgeons as well. And I think with a team approach, you really can have a more comprehensive program, which is a better experience for patients. Okay, so patient selection. Part of the reason that you're listening to this presentation tonight is so that you can understand what we are thinking in deciding on who is a good candidate for surgery. So we want to make sure that you as a patient understand the surgery and the risks of the surgeries. We want to make sure that you as a patient will also understand our calculations in deciding that the operation itself can be sustained by a patient, that they can tolerate the surgery. And that means sometimes there's additional workup included, which may include additional cardiopulmonary evaluation, etc. Again, it's not just about the physicality of what we do. As I mentioned earlier, there's psychological conditions that are highly associated with obesity. And part of your evaluation will include a psychological evaluation so that we can ensure that if there are any unrecognized conditions, that they are then identified and can then be treated. Or if there are known problems, that they can also be better treated and recognized before a surgery happens. Because as you see from the last line in this slide, we have to try and ascertain that you're going to be accepted for the lifestyle change and follow-up that's needed, really for long-term success. And that's kind of what patient selection is about. And so the next slide we like to talk about the results after surgery. And the way we describe this would be the percent of excess weight loss, which is a calculation that you can make if you know your ideal body weight. And for that, you can actually go to the internet, and the internet will derive this information from life insurance actuarial tables, where you can identify for someone at your particular height what the clinical ideal body weight is. And then to find out what the excess weight is, you can then subtract that ideal from the actual. And so that's what you need to know to be able to figure out, again, what your percent excess weight loss is after surgery is going to be. Now, after surgery, you're going to hear from us, and we're going to talk about after the sleeve or the gastric bypass, what patients typically may lose in terms of weight. Typically, after the sleeve, a patient may lose 60 to 70% of their excess weight. After the gastric bypass, patients may lose between 70 and 80% of their excess body weight. And then we'll also talk about the improvement in comorbid conditions, such as diabetes and high blood pressure, gastroesophageal reflux disease, etc. And it's not all about just medical problems. There are significant improvements in quality of life that we like to hear about. And there are certainly questionnaires that we can access that can help to ascertain this. But typically, we just like to hear about patients being able to do the activities of daily living with more ease, whether it's just tying your shoes a little easier, whether it's going on for longer walks, whether it's just having more energy. And we like to hear about this after surgery. Okay, as I mentioned to you earlier, we talked about what we think are good results. And I've listed, what we could consider good results and excellent results. And obviously, we want all of our patients to have excellent results following surgery. And then I've already mentioned this in a previous slide. And the benefits of laparoscopy, which include the faster recovery, shorter hospitalization, less pain, better cosmetic outcome, fewer wound complications. And so this is what we're going to focus on after surgery. And I think this is additionally the fewer cardiac and respiratory events. and these are some of the benefits of laparoscopy. Okay, surgeries following that we offer for bariatric surgery. So there's laparoscopic gastric bypass and laparoscopic sleeve gastrectomy. And you can see these options listed on the slides here. We'll go through those now. Okay, gastric bypass. It's been around for a long time. And it's probably the gold standard for weight loss surgery, even now, even after its inception, way back in 1964. How does the surgery work? Well, to summarize, laparoscopically, we staple the stomach to create a new little small stomach, which you see depicted here as the proximal pouch of the stomach. This is a 1 ounce stomach, and it's stapled from using what you see listed here as excluded portion of the stomach. So that's stapled away from that. A limb of intestines known as the roux, R-O-U-X. This short intestinal limb of intestines is then surgically attached to the gastric pouch. So that, as you see depicted here, once the surgery is done, food will enter the esophagus and the proximal pouch, and then leave the proximal pouch via the roux, and then move out your intestines in more or less the normal way. The bypassed stomach stays inside of you, and the digestive juices, including acids and bile juices that enter the duodenum, and pancreas juices that enter the duodenum as well, these juices then meet up further down on your intestines, where there's been a surgical rerouting, so that these digestive juices can still aid in the digestion of the food that you eat. So the surgery primarily works through a great restriction of meal size. There is a marked decrease in appetite, and less so some mild malabsorption of dietary fats. And that's predominantly how gastric bypass surgery helps patients to lose weight. From this slide, I included here so that you can get an idea. And this is, again, a relatively old study now, 18 years, and there have been several since, that demonstrate patients who get surgery versus patients who are similar in characteristics. In this study, the control group. Patients who do get bariatric surgery live longer than the counterparts who did not get bariatric surgery, who are just treated with medicine or otherwise. So we know that, again, the benefits of bariatric surgery extend to lengthening of longevity. This is the sleeve gastrectomy. And from the slide here, you can see that the stomach is now stapled in a vertical fashion, thus creating a narrow tube, which you see here is called the stomach pouch, but it's really more like a narrow conduit that helps to restrict meal size and control appetite in a way similar to gastric bypass. In this case, however, the stapled off stomach is completely stapled off, and this stomach is actually removed entirely from the abdomen. This is roughly 70 to 80% of the volume of the stomach. And so this surgery, as mentioned earlier, again, helps with portion sizes, and there's a marked decrease in appetite, just like with gastric bypass. But many of you are wondering which surgery would be the best one for me. Well, I'll just give you some basic points about each procedure. And this is not an exhaustive list of differences, but these are some of the major ones. So gastric bypass has been a well-established surgery with faster weight loss and more comorbid resolution, at least a higher percentage of medical problems that resolve, and they resolve quicker. The sleeve gastrectomy is less invasive than gastric bypass. But despite having a shorter operative time, the weight loss results aren't quite as high, nor is the weight loss as fast, as mentioned earlier. I did put on this slide that there's no dumping syndrome. And dumping syndrome isn't so much a complication as it is a side effect of gastric bypass. And in that patients who have gastric bypass surgery and then consume high sugar meals that are processed sugars that are found in cakes and cookies, as well as baked goods, these sucrose-laden foods can initiate a syndrome that is similar to hypoglycemia and also has a significant diarrheal component. So that doesn't really happen with the sleeve, but it does happen in gastric bypass patients when they do, again, have a high sugar content meal. Disadvantages of gastric bypass. Well, we do more in bypass, so it is a little more invasive. It is more or less permanent, and there's a malabsorptive component to the surgery. That's important to recognize because it means patients need to be much more cognizant about taking their bariatric formulated multivitamin daily so that they don't develop nutritional deficiencies such as iron deficiency anemia, a vitamin D deficiency that can lead to osteoporosis, and much less commonly, vitamin B12 neuropathy or thiamine deficiency that can lead to memory problems in severe circumstances. So there are other nutritional deficiencies that you're a little susceptible to with the bypass that are certainly rare in occurrence, but you should be quite cognizant of these differences when it comes to bypass versus the sleeve. Now, the sleeve, the data that we have on it is okay. It doesn't show as much weight loss as the bypass, and certainly there's maybe a little bit more weight regain with the sleeve than with the bypass. It is a permanent surgery. And it is important to recognize that in patients who choose the sleeve gastrectomy, gastroesophageal reflux disease, otherwise known as GERD, can occur after the procedure. And depending on the literature that you're looking at, it could be 10 or 20% of patients where this may occur. And if it does happen, it may be controlled with behavioral modification, or it may require medications like proton pump inhibitors or H2 blockers, or in the worst case scenario, it could mean a conversion to actually gastric bypass surgery to treat the problem. Okay, we're going to get into some slides that really sort of get into how to manage things in the perioperative period. And some of these slides are going to be do's and don'ts. So in the immediate aftermath of the surgery, in order to decrease the risk of deep venous thrombosis, which is abbreviated DVT, which are blood clots in the lower extremities. And these blood clots in the lower extremities, when they break off from the lumen of the deep leg veins, can move through the inferior vena cava and lodge in the pulmonary arteries and then become pulmonary emboli. And this can be a serious condition if it occurs. And the risks of this with either surgery are less than 1%. But in order to help prevent this phenomenon from happening, aside from the blood thinner that we're going to give you right before surgery, we are going to encourage all of our patients to be ambulatory in the immediate aftermath of the surgery. And this will help to promote blood flow along with the sequential compression devices that go along your calves to help keep that risk of a DVT or PE low. All right. Clear liquids you'll be on while you're in the hospital for 1 or 2 days. And typically after 1 or 2 days, our patients are discharged after the bypass or the sleeve. And I want to stress to you the importance of lifetime support and follow-up. I think it's one of those measures of success that we oftentimes overlook, but it is, I think, a characteristic of a patient who's going to be more successful when they're coming back and seeing us, and we can, really monitor their vitamin and mineral levels as well as track their weight loss. Again, after surgery, there's going to be a dietary progression where you start off on clear liquids for a couple of days, and then you move to full liquids. liquids. And then from full liquids, you'll move up to sort of soft parade foods. And we'll go through that when you do your diet class prior to surgery. There'll be medications that we're going to ask you to take in the immediate aftermath of the surgery. I mentioned the multivitamin, and then calcium with vitamin D is important. Protonix is a proton pump inhibitor that you're going to be on for 3 months after surgery, and in some cases, maybe longer. Activity, important to engage in a consistent exercise routine. And I have patients sometimes afterwards who say, well, I do a lot of walking at work. Well, that's good. However, you need to have focused, concentrated exercise. That's daily, and we all need that. And that's very important for your progress after having these kinds of procedures. And again, I mentioned follow-up, and I'll reiterate it here. Important to make your follow-up visits and to just kind of make it something that's just going to be part of your life, at least annually after the surgeries. We do ask our patients to take a little bit more time off from work than maybe some other practices. It's because our experience tells us that it's not just the physicality of their recuperative period that's important. It's about taking that time and learning to adopt these habits in terms of how you eat and drink differently. Keep in mind that bariatric surgery affects one of the most primordial behaviors that a human can have. Learning, when we all drink and learn to eat when we're infants, there's really no restriction at all on how much we can take in. And when we alter that ability, it really is a profound change, and it requires time to get accustomed to. So we really want you to take a little bit more time off from work so that this process doesn't extend into your work life too much. Okay, just to go through these slides, again, routine patient follow-up is essential. We do suggest for women of reproductive age that you're going to want to avoid pregnancy for the first 2 years following surgery. There are certain foods and medications that you're going to avoid following surgery. A couple of examples would be non-steroidal anti-inflammatory drugs. This is a class of medications known as NSAIDs that are ibuprofen, Aleve, Motrin, Naproxen. These kind of medications have an effect on the stomach lining that can promote ulcers, especially in patients who are choosing gastric bypass. So medications like that, or oral steroids, or aspirin, we're going to ask you to leave those alone if you can. And some foods may be disagreeable to some patients. The more common offenders would be red meats, or in some cases, chicken. Now, these are not absolute prohibitions, but you may find that after either procedure, for instance, you may not like red meat anymore, even if it's moistly prepared and you're just consuming very small amounts. We have a support group that meets monthly that is, I think, essential to the early postoperative recovery. And I highly encourage every patient to attend it. It's virtual right now, so there's good access for you on a monthly basis. Okay, after surgery. So I often have patients who, for some reason, inexplicably, after surgery, they schedule some kind of event with the family that they have to fly to. And this is in the immediate aftermath of the surgery. I will tell you now, it's important to clear your calendar for at least 2 weeks after surgery. Rearrange your obligations and commitments. Be ready to focus on your recovery needs. And we certainly don't want you flying for over an hour after within 30 days of surgery. So be prepared. Take the time. This is not surgery to have your gallbladder removed or an inguinal hernia fixed. This is major surgery, and it requires the proper time to recover. Complications after these procedures, thankfully, are not terribly numerous. And in general, I think they're far less than 15%. But what you can see, and again, these are rare, but Leaks after bypass or sleeve these days are far less than 1%, and usually somewhere around 0.2, 0.3% for either procedure. For gastric bypass surgery, there's a risk of intestinal obstruction or gastric obstruction, which we can also call strictures. Either one of those may require either additional surgery or additional endoscopic procedures. But the risks of bowel obstructions are 0.5% or less. The risk of strictures can be 1 or 2%. After the sleeve, there is that risk I already mentioned of gastroesophageal reflux disease, which can be 10 to 20% of patients. So I'm going to wrap up the talk. In summary, we know that obesity is a condition which severely affects the health and quality of our patients' lives. We know that diet and exercise alone in patients with class 2 and 3 obesity may be of limited value, actually. And so we think that patients in this class of obesity can benefit from surgery along with proper diet and proper exercise habits. And we know, based on reams of studies, that the risk of operating is greatly outweighed by the enormous risks of remaining obese and developing all the medical problems that we know that are associated with the condition. So remember, surgery is a tool for success. It doesn't work in a vacuum. It works as an adjunct to patients who are, or for patients who are committed to the lifestyle change and are prepared to adopt new habits. We believe a multidisciplinary approach is a key to a successful bariatric practice. And as I mentioned earlier, the three-pronged approach, diet, exercise, and surgery for our patient population is, again, a key to success. All of you are here, which means you are motivated to have a bariatric surgery. Along with that motivation, we hope that you be prepared and be ready for what's a wonderful change in your life. And I can tell you that I've had many patients who've just said that this is the best decision that they've made for themselves in their life. And we hope to be a part of that change for many of you. So I'm going to stop the talk here, and I'm just going to finish with this last slide. This is how we will handle the question and answer session. It's preferable that you click the hand icon and then raise your hand, so to speak, and we'll have a tracking of the order in which you've done this, in which case we can acknowledge you. Once you're acknowledged, unmute, we'll call your name, unmute yourself, ask your question, and then mute yourself again, and also take down your hand, okay? If you're calling into the meeting by phone, you can press 6 to unmute yourself. Then when you're finished, mute yourself once more, okay? Thank you everyone for listening this evening, and we'll now open it up for questions. We can conclude the recording now.